Hello, you're welcome to this edition of the African Catalyst Resilient Africa Week. And we are in the third day and the first session of today. That's the second to the last session. And we'll be having our panelists discuss with us on the road to universal healthcare and the role for private sector to intervene. I will hand you over now to our moderator, Dr. Adepeju Adeniran, who will continue to share with us on the various issues being discussed. Thank you and have a good time.
So, a very good morning and you're welcome to our session. I'm very happy to be here. I'm very honored to be moderating this session with a group of esteemed panelists. I'm so glad I'm not in the hot seat. So all I'm going to be doing is asking the questions and then sitting back and letting them, take all the fire and all the heat. Right, so we are all very invested in healthcare in Africa. And healthcare, particularly at this time, is very topical, not just because we're in the middle of a pandemic, which I think underscores what we've been trying as healthcare professionals to say, that you cannot have development in any situation, but then especially in the low to middle income country, if we do not deal with healthcare development. And healthcare development as using the health system frame, we would have to consider healthcare resources, human resources, technology, healthcare access, financing. So it's a good time, I think, more than ever, to speak about healthcare in Africa. More to the point today, we are focusing on universal healthcare, the road to universal healthcare in Africa. And there are many definitions that we can find when we're speaking about universal healthcare. But the most important, the most telling is very simple. Think about universal healthcare, meaning every single person must have not a single barrier in being able to access healthcare for every single need. It's mine. It's not anyone else's. But when you try and collate every discussion about universal healthcare, you find that at the end of the day, those are the nuggets that keep propping up. We must be able to provide healthcare for everyone, not just for the rich, not just for the advantaged, but we must be able to provide that health for everyone. Oftentimes, though, when we speak about this universal healthcare, we are tending to speak about something that looks like primary healthcare. And that is because the two of them share a lot of things in common, even though we cannot use them intermittently. But as we go along, we'll see why we would have to, in very many cases, slash universal healthcare with primary healthcare. Because while secondary and tertiary, other aspects of healthcare are very important to improving the framework, primary healthcare is the most accessed tier of healthcare. It is the level which most people will, many lucky individuals, I'm going to say, primary healthcare is probably all they will need for the rest of their lives. We all will not need secondary or tertiary healthcare. So if we can have this discussion and say, how can we develop primary healthcare as a proxy to developing universal healthcare, then I think we're certainly on the right path. I was going to go into a little bit of the history behind universal healthcare, but I think suffice to say, we've been at this for a very long time. But fun fact is the Declaration for Universal Healthcare was in 1978, which is basically as long as I've been born. We've been trying to get universal healthcare off its feet. And sometimes when we think about it, when you actually calculate, I mean, since 1978, globally, everyone had realized that we needed to sit and have this discussion on universal healthcare. This was 1978. To put that in context, it's 42 years. And it's not just an African problem, but if you ask in several other healthcare systems, in 42 years, how far have we come? So joining me today, I'm going to let like I said, I'm very, very excited to be on this team, moderating, like I said, the team of experts. I'm very happy to have them introduce themselves, and then we are going to fire them with these questions about how in 42 years, how far have we come? What lessons have we learned? What have we done well? What have we done not so well? And how can we improve for the future? Bring that context particularly to Africa. So once again, my name is Dr. Adeniran. I'm very happy that you're here with me today. So I'm going to introduce in no particular order, but because she's also wearing glasses like me, I'm going to start with Dr. Buki. I'm going to start with Dr. Buki. So Dr. Joan, it's simply your glasses that you're not wearing, that's all. That's how you're number 2. So Dr. Buki, thank you very much for joining us. And I'm also joined by Dr. Joan Osoro. I'm very excited because this conversation is not just focused on Nigeria. Dr. Joan joins us from Kenya, which underscores the fact that universal healthcare is a global problem. So we're not just talk about Africa and all. We have insights and conversations also from Kenya. Dr. Joan is also an expert, but I'm going to let her tell you about that. In Nigeria, with me, the only man on the today is Mr. Kola Oni. Mr. Kola is also from Nigeria. And again, I'm going to let them self-introduce. And they will speak on who they are and what they've done for about a couple of minutes, and then I'm going to fire them with the questions. As you can tell, I'm very excited about this firing them questions issue. So it's going to be in order of Dr. Bukola Shittu-Muideen first, Dr. Joan Osoro, and Mr. Kola Oni. So each person would just really want to have a little bit of a quick background on who you are and what you do, and then we come back and start the questions. So Dr. Buki, over to you.
Thank you very much, Dr. Peju. A very good morning to everybody, and thank you for this session. My name is Bukola Shittu-Muideen. I'm project coordinator for PharmAccess Foundation in Kwara State. PharmAccess is an entrepreneurial organization that is working to ensure the delivery of healthcare solutions that leave no one behind, using our approaches to make health markets work to achieve universal health coverage. And basically what I do as the coordinator, as the project coordinator in Kwara, is to support the state as a technical partner in ensuring the implementation of the statewide health insurance scheme, because we know that through health insurance, effective and efficient processes that will lead to the attainment of UHC in no time will be achieved. So I coordinate the services here. The process is there on behalf of PharmAccess Foundation. And of course, at PharmAccess Foundation, we have our role that we play within Africa continent to ensure that health markets work, as I mentioned earlier on. And of course, we are leveraging on digital technology as opportunities in healthcare to ensure that UHC is attained as soon as we can within African community.
Thank you, Dr. Bukola Shittu-Muideen. PharmAccess, I happen to know of PharmAccess. I happen to work maybe with PharmAccess. So I'm very excited to ask a few questions about that. I know that you're PharmAccess Kwara State, but we can speak about what's happening in Kwara as well as Lagos, as well as anywhere else in Nigeria that Kwara is in. Yeah, right. Definitely. I'm going to go on a plane real quick and fly to Kenya. And Dr. Joan Osoro is going to give us a brief background on her name. You already know her name, Dr. Joan, and you already know she's from Kenya. So, but we want a little background on what she does, and then you can see her expertise from there. So, Dr. Joan, over to you.
Thank you very much. As you have heard, I'm Dr. Joan Osoro-Mbui. I'm a health systems specialist, currently technical advisor for Kenya Healthcare Federation. Just to give you a brief, Kenya Healthcare Federation is the umbrella body that represents all private healthcare players in Kenya, and really seeks to strengthen and support and network the 6 different pillars of healthcare. That is human resources for health, service delivery, supply chain management, leadership and governance, digital care and IT, and to support infrastructure. Kenya Healthcare Federation sits in the Kenya Private Sector Alliance and is very key in collaboration with the government of Kenya to ensure that the needs of the private sector are heard, and then we also play a huge role in lobbying. So my role there as a technical advisor is to support in the human resources season. During COVID, we've done a lot of capacity building of both front them in preparedness for COVID-19. And secondly, in the projects committee, where we are sitting and acting as an incubation hub to help our members to get funding and support for the various projects that they have running or would like to run. So that's what I do. My background is a medical doctor, having worked in senior management at the top hospital in the country, the Nairobi Hospital, where I oversaw implementing new service lines and quality improvement, public health security through disaster preparedness, research and education. So I'm excited to be part of this panel. Thank you, Dr. Peju.
Thank you very much. If I wasn't already very impressed by your background, having read up on you and what you've done in Kenya, let me just so we'll very quickly now, we're going to move to Mr. Kola Oni, who's going to give us a little background on what he does and his expertise in the field of universal healthcare. And then we'll circle back to really get into it. Mr. Kola Oni.
Okay, good morning, everyone. I'm not a medical doctor. So I'm an accountant, and over the past 1.5 decades, I've worked in finance, general finance across different sectors. But in the past 6 years, my focus has been around raising healthcare financing and supporting the growth of the private health insurance market in Nigeria. A few decades ago, Nigeria's healthcare sector was totally devoid of insurance. But just about 15 to 20 years ago, we started a new national health insurance scheme, which has actually catalyzed the intrusion of private health insurance, the growth of private health insurance in the country. But over the past 6 years, as I worked in private health insurance and insurance industry likely, I and a couple of partners have noticed that insurance is just a bridge to the real healthcare delivery. And there was an important need for us to actually develop healthcare organizations that are sustainable, that are operating at scale, and that are following proper corporate governance models that we see across other parts of the private sector. So about a year ago, I co-founded an organization called Afya Care Nigeria to operate in the private healthcare space in Nigeria, starting with Nigeria, but ultimately expanding across Africa. And our plan is to create an integrated healthcare platform that would make healthcare accessible and affordable. It's been about 7 months since we started, and we currently own a 100-bed hospital in Lagos, but we do have a target to expand rapidly so that we can form a proper healthcare organization. It is from this context, from these viewpoints, that we're going to be talking about the issues about universal health coverage today. Thank you.
Thank you very much, Mr. Oni. And as you spoke, I have a number of things that I have noted, and this is true of everyone. So that might modify the conversation as we go on. But what we're going to start from is back to you, Dr. Shittu-Muideen, where we are going to talk about universal health at the national attempts or the state attempts to achieve universal health care. We want to speak about the public sector's role in it so far, and why, one, the private sector is uniquely qualified as you wish to fill in the gaps. And before this, we're first going to talk about what are the gaps, what are the fails and the challenges that were encountered as the public sector tried to achieve this health, and so at some point they were like, okay, stop. We think at this point we should let another player get in. So a little bit of, kind of like a historical context on why we believe, or you believe in this conversation, that the private sector is uniquely qualified to fill the gaps.
Thank you very much for that opening discussion. It's something that is very pertinent now. In PharmAccess, we support both public and private sector to bridge a lot of gaps. And the main gaps that is of big challenges in the attainment of universal health coverage includes the issues of low quality, the issue of poor access, and of course, poor investment opportunities in health. And because we know that there is a disconnect around these areas, we as PharmAccess, we have come to ensure that we support the demand and supply side, and of course, investment. Because once you're able to support the demand and supply side and investment, we'll see that there will definitely be improvement in quality of healthcare services that are being rendered. And of course, we also know that access would be improved, and definitely investment. And how does PharmAccess do this? PharmAccess works, like I said earlier on, with both public and private partners to bridge this gap that I've highlighted previously. And of course, increasing access to care is definitely through health insurance, which is a very, very strong point for us. It's an area of strength for us as an organization. And of course, through this, we use new digital forms of health financing to deliver to mobile health contracts. Secondly, we also help healthcare providers to get access to financing so that they can also invest in improving quality healthcare services. We know that once people are able to have trust in accessing quality healthcare services, it would bridge the gap of access. Once you can guarantee quality healthcare services being rendered at the facility level, whether at the private facilities or government facilities, as the case may be, it's a good way to ensure that you deliver health services. And of course, through the deployment of our international standards, quality improvement standards, which is the Safe Care Standards. The Safe Care Standard is a quality improvement methodology that was birthed by 3 organizations: PharmAccess Foundation in Netherlands, that is where our organization, of course, the Joint Commission International of United States of America, and the Council of Healthcare Accreditation in Southern Africa, COSASA. So these 3 organizations, they identify that for resource-restricted settings in Africa, especially in sub-Saharan Africa, where we have issues of low quality. And of course, we know we have issues of inadequate resources, whether we are talking of human resources, equipment and infrastructure, or finances. So they were able to design the quality standard, the safe care quality standards, which uses a stepwise approach to mentor and facilitate healthcare facilities to ensure that they are able to attain the quality standards at the facility level in a stepwise manner. And once we see that you are able to ensure that, once you're able to key these three, like I said earlier on, once you're able to key these three areas together, pulling demand, the supply side is in order, and investments in health, you see that the vicious circle would be like sort of a chain reaction that would ensure that people can have trust within the system. And of course, like I said, when I was giving my introduction, that at PharmAccess, we work with a lot of digital solutions, because we have identified over the years that digital solutions pose a lot of opportunities within the healthcare space. You would agree with me, a lot of people would agree with me that as far as we say African countries are, even in the remotest areas in Africa, you see people having their phones. It may not be a smartphone, but people have their phones. People use their phones to do a lot of things. And we're able to think out of the box innovatively to say, how can we leverage on these simple solutions to deliver healthcare solutions within Africa, such that every individual, irrespective of socioeconomic class, irrespective of religion or tribe or race, everywhere in the world, you can have access to care. So simple mobile phone can accelerate better. We found that simple mobile phone, as simple as it could be, can accelerate better and affordable care for millions in Africa. A lot of African markets can find themselves trapped, because we find that a lot of African health markets find themselves trapped within these challenges that I highlighted earlier on. And using these digital solutions in very, very sustainable manners, in very, very efficient manners, you would agree with me. And of course, we have a lot of projects that I've been working on in the country with state government, and which I'm sure as we speak on, I will still mention, that is allowing people to access quality, affordable, equitable healthcare, all in the spirit of ensuring that UAC is attained as soon as possible, especially in Nigeria and Africa as a whole. Thank you.
Thank you very much, Dr. Adebukola, Shittu-Muideen. I love the fact that you actually started right off the bat from the solutions I've already put in place. So I'm going to dial a little back and say that the solutions that and I love the fact that, once the private sector in this situation highlighted by the work of PharmAccess got in, they quickly looked at the gaps and went for quality standardization of the facilities and the access, the delivery. So basically looking at demand supply pool issues. Of course, with demand issues, talking about trust, the patient or the client or the consumer being able to trust the system that they will get the results that they're looking for, which again, we can say from your conversation that was probably lacking in the prior attempts to access universal healthcare. The patient or the consumer wasn't sure that I would be able to get the best care and that I would be able to get the most standard care. And so when an organization like yours came in, it was like, how do we fix those gaps? And also investments. Now, for the medical people, when I started out in clinical medicine, I didn't want to be interested in economics and money and investments, and I just wanted to treat my patients. But you find out as you go along in the course that if you don't talk about money in healthcare, you really are not, and it's something that we as medics is something that we've had to wrap our minds around, because it feels very, how should I say, opposing to the views that medicine is about. It's about service and, the oath and all of that. But, being able to do that, someone has to pay for it. And somewhere in Africa where the patient or the consumer is unable to pay efficiently for it, what do we do? So investments quality and digitalization, which I would love us to go very, to take a deep dive into it, because this is digitalization in a low resource environment. And I'm going to take that digitalization in a low resource environment, and then I'm going to fly on my plane to Kenya, because Kenya is one of, as we know in Africa, Kenya is one of the tech giants and tech examples that we're really proud of in Africa. So we would like to know from you, Dr. Joan, a little background on what the context of Kenya. Dr. Muideen has really gone in and told us what it's like in Nigeria, but I'd like to hear from you about the Kenyan experience in trying to deliver universal healthcare in Kenya. And if you could speak a little bit more about digitalization in Kenya to see if we can compare and contrast with the Nigerian situation, that would be very helpful. Dr. Joan, over to you. Okay, so you need to unmute your mic, Dr. Joan. Okay, Dr. Joan, your mic is still. Oh, yeah.
Sorry about that. Thank you very much.
Yeah.
I hope I can share my screen. I had some figures which would help us appreciate the utilization, because then we will see the Kenyan journey. Okay, thank you. So I hope you can see my screen. If you can, please tell me. Can you see it?
No, we cannot see your screen, but I'm sure it will come up in a couple of seconds.
Okay, fine. So the Kenyan journey has been exciting. We've had the good, the bad thing, not the ugly. But some of the successes that we've had in universal health coverage have been an improvement in increased government spending. In various challenges that we have is allocation of spending from our healthcare budgets, and the Abuja Declaration having advised that we consider 15% of healthcare budgets. Many of us fall way below. And for Kenya, it's continued to fall low since the year 2016. To the point of being at 5% pollution in our country, then we were able to see increased spending in our counties and their allocations ranging from 21 to 30%. So over a period of from 2002 to 2018, because that's the latest data I have been able to, we have been able as a country to appreciate 867% growth in allocation to health. The only challenge is that because spending, or rather our budgets in Africa, cannot be compared to the developed world, what it comes to, even if it's an improvement from 16 billion to 155 billion in healthcare, you still do not find it to be enough to support the initiatives. Therefore, then having to work with pooled funds from donors, from private sector, and for us, that has been a big deal. And just to add on to that, having seen growth of our National Health Insurance Fund from 18% in 2013 to 40% in 2019. So just your opening statement when you began, that universal healthcare is providing quality healthcare to everyone at an affordable cost if we can protect them financially. And that being said, because private sector is a big player, despite the fact that we have a relatively mature private health insurance sector. However, they only cover 2% because only those who have relatively well-paying jobs are able to pay for themselves to get private health insurance. So when you look at 2% vis-a-vis the 40% from the National Health Insurance Fund, then you see there's room for growth in the private sector, in healthcare financing and protection of our people. And of course, with COVID-19 having come on board, that number has gone lower because people are not paying premiums. Everyone is holding on to their money, not sure how the economy will turn out. The other success that I can talk about is proactive engagement and increased service delivery. And for us, because primary health care, as you said, is not synonymous with universal health coverage. However, if we're able to adequately provide primary health care, and that's our reproductive, maternal, neonatal, and child health, our vaccination, and of course now with the rising burden of non-communicable diseases, then we see ourselves improving in the care that's being given.
So I can see your screen, but do you mind opening it in full screen so that I'm able to appreciate?
Oh, good. Excellent. That's good news.
Yeah.
Okay. I think it's taking a while. So
once you open it in full screen,
excellent.
Yeah. Okay.
So if I was just to share the allocations, the healthcare funding, the graph shows you how the increase in funding has gone from 2002 to 2018, and that's the 867% rise. And the graph on the right then shows you the spending in the various counties, because for us, unlike for you in Nigeria, devolution is relatively young. As you can see, it began in 2013 to 2014. The other thing that is important to review and utilization. These are the evaluate the efficiency of universal health coverage.
I think we might be having a little bit of network issues on Dr. Joan's end, so we cannot hear her, but we can still see your screen, Dr. Joan. I can still see your screen. I just couldn't hear you for a minute, which is probably network. So the screen that I can see is, the graphical representation of 2013 to 2018, the changes we've had. So if you can pick up from there.
Okay, thank you. So we've had an increase of presence of healthcare workers. Availability of essential drugs has remained similar, and interestingly for us in Kenya, the public sector has a higher percentage of availability of essential drugs. The thing that we have not done very well is availability of essential equipment. And we had a bit of a challenge with our managed equipment services, which then took us back from 76% to 50.9%. And that's an area of growth for us and an area of focus as a country. Otherwise, in terms of diagnostic accuracy and adhering to clinical guidelines on the tracer conditions, we have seen an improvement relatively, remaining the same, but those are some of the successes we can talk about. So just summarizing the challenges, we've had insufficient funding, mainly because of the allocation, despite the increase in percentage. Is being driven because of having to pay for healthcare services out of pocket. And then there are certain areas that have had authoritarian political leadership, three disparities, mainly where you have more of a challenge. Counties like Marsabit that have the lowest level of equipment, Turkana, Kitui, and Kilifi, parts of Kenya where they're still struggling to be able to meet the needs of the universal health coverage. So I hope this gives us a peek into where we are in universal health coverage as Kenya. Thank you.
Thank you very much, Dr. Joan. It's a little bit of the fact that the network was dropping in and out, and so we couldn't hear you all the time. But your presentation was very, very, very helpful. I like the side-to-side comparison of the challenges and the successes, and something we keep coming back to is the Abuja Declaration, and as is with you in Kenya, of not being able to hit where you need to be with the Abuja Declaration, as is with just about everywhere else in Africa, that 15%. I think Nigeria now, 15% of annual government budgets. Okay, so I'm going to talk to Mr. Kola Oni, who's going to talk about the numbers, but I think we should dedicate maybe 2 minutes to talk about the Abuja Declaration in Africa and why we think national governments in Africa, and maybe about the two countries that are represented here, finding it difficult to put in practice something that we all sat down and health experts said this is the and let me remind us that the 15% is the minimum it was proposed as a minimum of the healthcare budget per year, and yet even at a 15% minimum, that this is the least you should be spending to improve your healthcare system. Very many national governments in Africa are unable to reach that. That is not to say they haven't been subnational, like you said in Kenya, they haven't been subnational or regional successes, that is where, or attempts to reach that. Mr. Kola Oni will be talking to us about the financial aspect of the healthcare system, and he's particularly well placed to say that, being that as himself working now as one of the private players. I'd like a little background on what the general your general impression of what the investment space in healthcare in Africa looks like. What makes it attractive for anybody? What's your general view of what the ROI would be as is, and what is the potential of the healthcare space? Why should any private player be very excited to get into the game? The good thing is, you said, oh, you're not a doctor. Well, that's great, because almost 3/3 of us are just clinical people, and we just want to get well. And there is that mission, but maybe once in a while we just need to sit down and listen to the numbers, people. So I think this is a great point for you to come in and really, tell us about the numbers.
Okay. Thank you so much, Adepeju, for that. So talking about the numbers, the investment climate for healthcare at the moment in Africa has even been further revalidated by COVID-19. It's like a virgin territory, to be honest. And this is because over the years, the conversation around healthcare in Africa, in Nigeria specifically, has actually always been dominated by things like the Abuja Declaration, which you mentioned. But one thing we always all seem to forget is that just like we have the Abuja Declaration, we have had so many other declarations that have been made over time. We've had declarations that have been made for education. We've had declarations for infrastructure. We've had a lot of money now being spent on debt servicing across the continent. So when we say 15%, it's always very clear that this is probably something that is not even achievable in the next couple of decades. But what is driving all these conversations, at least from a private sector point of view, is that we keep looking at healthcare as if it's like a small pot, as the financing is a small pot, and everybody just needs to go to that government pot and share from it. Meanwhile, we think the better way to look at this thing is to actually go outside of the public sector and ask ourselves that what can we do to bring in private capital into healthcare financing in a way that is going to be sustainable and in a way that is going to last and cater to everybody. An interesting fact as we've looked at healthcare is that what it costs you to build the average hospital is what is going to cost you every year to maintain it. So maintaining healthcare services, maintaining provisioning of healthcare is not a very, very cheap venture. You cannot just go somewhere and believe that you can put in infrastructure. That same cost of infrastructure, you will need to spend it every year for you to make sure that that facility is operating at optimal capacity. And that goes straight to the heart of what we describe as sustainability. How do we expect the government to vote billions of naira to providing healthcare infrastructure? It's already a struggle when they were able to provide that. It was already a struggle for them to be able to provide that infrastructure. When we then realized that the amount of money that they've spent to provide the infrastructure is what they will need to spend every year, or close to that is will need to be spent every year, just for them to make sure that this is operating, assuming they don't charge anything for these services that they are rendering. And that is where private investment comes in. The opportunity is actually really, really there. I always like giving the example of telecoms, where telecoms in Nigeria, for instance, was a country where, as of 2002, we had just about 400,000 telephone lines. And today we have about 150 million telephone lines, or even more active lines. I'm talking about active lines now. So that is the way we think healthcare opportunities are in Nigeria at the moment. We haven't had a lot of investment. So a lot of the areas from diagnostics to OPD to primary care to tertiary care, everything is actually still really quite like a greenfield. It's just open there for investors to come in. But why are investors not coming in? I think the first thing is, let's even talk about the mindset. The predominant mindset, as I mentioned, is that healthcare is really meant to be seen as a practice rather than seen as a business. Over the past decade, a lot of healthcare practitioners started realizing that this is not something that is going to be sustainable. We do not have the capacity, we do not have the expertise to actually run the business side of this healthcare project. We have the passion, we have the knowledge, we have the experience, but immediately after a doctor consults with a patient in the OPD department, if the patient is not going to be admitted, almost every other thing that happens to the patient from that point onwards is very, very clearly just all about just business. It has nothing to do with money. It's the same way it needs to be done in a bank. It is the same way it needs to be done in an insurance company. It is the same way it needs to be done in a manufacturing company. So that mindset itself has been limiting the investment opportunities that are available from a healthcare point of view in Africa. Another thing that we have noticed is that there isn't corporate governance, and this is also because a lot of private health institutions are not managed like businesses. So we have a lot of one-man businesses, and what typically happens is that as the founder gets weaker or ages, the quality and everything about the hospital just seems to decline with the age of the founder. And in a lot of instances where we even see those founders dying early, it's always a very sad situation when the institutions that they've created simply just goes down with them. There were two other key points that I would like to mention that needs to be considered even as we tap into these opportunities for healthcare investment is scalability. Scale is absolutely essential in healthcare, whether we are doing it from a government point of view or we're doing it from a private sector point of view. But the private sector may be better positioned to provide this simply because of the unique lessons, the unique experience that private sector players typically bring to the market. But if we do not go for scale, if we do not think about this as a very, very massive project, long-term, requiring a lot of commitment, a lot of investments, we will keep ending up with micro projects that are not going to be sustainable and that will not benefit from economies of scale. Even within the government system, within the public system, as large and sprawling as the public healthcare delivery sector is in Nigeria, for instance, you will notice that a lot of the institutions are operating largely almost in a siloed perspective. We don't have a national framework for recruitment, for a national framework or platform for purchases, for procurement. The last time I remember in 2003, when we had a massive exercise that was done on a large scale for procurement, I was in 2003 in Nigeria. I don't remember anything close to that happening again. So thinking scale is one of the key things that needs to be taken into consideration as we try to use the private sector to drive universal health coverage. The final thing I'll mention on this investment thing before I just speak generally on other things is the issue of capital management. When business owners are speaking to providers of capital, there's a particular language that needs to be spoken. But when practitioners, healthcare professionals are speaking, there is also a different language that they speak. So those two languages are actually different. There is a need for both sides to learn how to speak the other side's language. And one of the things that we're doing in Afya Care is that I'm taking this call from a hospital, but it's just for me to learn the language of what the doctors like talking about, so that when I go to financiers who I know their language very well, I will be able to explain to them and talk to them about all of these things that is available. So that ability to raise capital, that ability to actually let the private sector see how healthcare can be sustainable, how healthcare can be profitable, is extremely critical. Now, if I tie all of these points I've made back from investments into universal healthcare, what I would say is that a lot of people, Nigeria has a lot of people that are poor. Africa as a whole has a lot of people that are poor. What that means is that we need to find innovative solutions to the delivery of healthcare. We do not necessarily need to import some of the expensive processes or procedures and the way they are being done outside the continent, but we need to put our best heads together from a business and a practice point of view to work together to come up with innovative solutions that would be able to deliver quality care at a very, very good cost, which is why we need to think of volume, we need to think of scale, we need to think of how to raise cheap financing, we need to think of how to build institutions that are going to be long-lasting, because the more your institutions die, the more the systemic cost, because a hospital that was built that is now abandoned is actually a cost that was spent on healthcare that is now wasted. But when your institutions and your systems are more sustainable, you keep finding ways to retain your cost, and overall, over a long period of time, you will find out that we would have brought down the cost of private healthcare. And as we bring down the cost of private healthcare, we are essentially going to subsidize the entire healthcare ecosystem. when people go to the hospitals or when people go to some are looking for cost. There is a way in healthcare systems that we can take money from those who are looking for experience and take a bit of money from them and use that to cross-subsidize those who just need access to care. And that's the vision at the end of the day. And yeah, so I'll probably just stop there so I don't take too much.
Yes, I was going to, because there are many nuggets I would love to get back into, but hopefully as we continue the conversation, I will be able to circle back on that. So I'm very interested in a couple of things that you mentioned. First of all, recognize that you basically told us clinicians to fall back on on many of the capital and finance decisions. You said just see the patient, and after you see the patient, everything that happens is a business conversation. So we heard our sub and we are taking it. We are
say that in case I need to say doctor tomorrow.
Right. Just I don't know about the 3 people on this panel, how happy they are to see you in the clinic, but and any other doctor who's watching, he has kind of offered what is a little bit, what looks like an apology anyway, but yes, yeah, I think it's very valid to say that indeed very many decisions after the clinical experience or the clinical interaction are actually business decisions and business business activities, and that's absolutely correct. So I'm going to, and then other things that you mentioned is that because of the resource restraint in Africa, we're going to need solutions that are very, very innovative. How do we use our context with our context? How do we basically find the wiggle space between that, and also the core of what you actually said, which is that from your experience, you don't think the government has been spending in a way, the realization that that spending has to be sustainable. And oftentimes what we like to do is huge bolus investments into, and then, think, oh, you know what, I spend $1 billion or whatever, not realizing that if I spend $1 billion, it has to be a continuous spending. And that is the part that, in your opinion, you think that governments have not really been able to grasp the concept of. So, and I was going to take that right back to Dr. Shittu-Muideen to speak on that, and very, 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 very quickly, because we might need to take some questions from the audience. And if you're listening to us, please feel free to let us have some of the questions that you have for the panelists, and I will direct it to them. Dr. Mui, do you really want to quickly jump in to specific innovations that have happened in our environment, especially that low resourced? And I'm saying this because I feel like, because we operate in a low resource environment, there are many lessons that Africa can actually teach other people, other high income countries, if you will, from the successes of this low resource innovation. So if you want to jump in into that real quick, Dr. Shittu-Muideen, we'll be glad to hear from you.
Thank you very much, Dr. Adepeju. I'm happy to be back again. Yes, there are lots of opportunities and, of course, innovations that can drive processes within the healthcare space and ensure the attainment of universal health coverage. What is pertinent and very important for people to understand is that the issue of trust is very, very important. Now, we've been talking about a lot of people invest, even governments, pumping a lot of money into healthcare space and even other sectors and all that. But you find out that we don't really have anything to show for it over the decades, over 4 years, decades, and even more. So we need to ensure that we earn the trust of the populace. And how do we do this? A simple solution digital solution whereby you have all the stakeholders within the healthcare space, where processes are transparent, where processes are efficient, where you have direct access to and from end users. So it is very, very important for us to build on trust, because when we build on trust, the digital solutions ensure efficiency of processes, transparency of processes, and when we are able to establish the trust issue, then people will be able to say that, yes, they want to bring their resources, they want to bring more, even whether individuals or even donors or even governments. So we need to see, people need to see that they can trust the system. And of course, very importantly too, from the public point of view, we need to see the government have more political will and of course choice. Because it's one thing for you to say, yes, you have made Abuja declaration, they've made a lot of noise about it, we have our laws in place, we've made our laws mandatory. How have you been able to take it to the next level? How have you been able to implement what we have declared we're going to do? So the political will and the political choice is number one. Then very, very importantly too, still talking about trust, data. We need to ensure a data system, and the digital platform it's a very efficient way to have a data-driven system for the health system, where most of the effective, you have a lot of processes flowing. It flows in a particular way.
I'm sorry to cut you. Could we have a specific example, a working example of that, without going into too many details, a working example of one of these innovations we're talking about? I'm very interested in data, but you can jump in.
Yeah. Thank you. In PharmAccess Foundation, we have our sister company, Kepe. I'm sure Dr. Joan would have heard about Kepe, because we do a lot of work in Kenya too. Kepe is a digital platform whereby, from the demand side, so the health insurance is in place, that is backed up by law, needs to be mandatory, because if health insurance is not mandatory, the pool will not be large enough. Like Mr. Kola said earlier, we need the volume, we need the numbers. So at the back end, the Kepe system, for example, in Lagos State, and of course, Kwara State is also tapping into that system. The health insurance schemes are being supported by the Kepe digital platform, whereby you have the registration, the enrollment, and you see the process flow from where people enroll, where people are registered, from registration to enrollment, and their journey, their healthcare journey, the holistic management from the front desk, where you are registering, even at the clinic, how people are being seen, are being managed for different healthcare issues, primary healthcare issues, secondary healthcare issues, and all that, up to the point of the specific interventions that are rendered. So when you're able to build a platform that everybody, whether you're the healthcare provider or the consumer, in this case, the patient, you see the process flow using just your phone, that will build trust. And I can categorically say that where you can build trust with technology, the dream of access to quality healthcare is surely guaranteed, which you also need to attainment of your health coverage.
Thank you very much. I'm glad for that specific example, and also because I'm glad for that specific example because it also answers one of the questions we're seeing from one of the members of the audience, who says, what is the level of technology adoption and implementation in primary healthcare for the delivery of universal healthcare coverage in Africa? So on two levels, you want to talk about technology and you want to talk about universal healthcare. And I think Kepe very nicely answered that question. And he said, because this is because primary healthcare plays a major role. You are absolutely correct. Thank you, Mr. Duale. So I'm going to take the next question. So that question I consider it answered. For Mr. Kola, raising capital funds for a startup pre-revenue is during the COVID times is presenting a unique challenge. So do you have any recent success stories? And I'm going to give that to Mr. Kola, and I'm going to give this directly a fantastic question to Dr. Joan. Real quick, I think we're we'll have to hurry it up and then move this interaction to it. But Dr. Joan says, what role does the current lack of human capital or medical personnel play in trying to achieve universal coverage, and how can this change? And I think you are, very well placed to answer this. I'm going to let Dr. Joan pick her question from John, and it again is, what role does the current lack of human capital or medical personnel play in trying to achieve UHC, and how can we change this?
So thank you for the question, Mr. Adesioya. Human capital lacks in terms of quantities. When you look at Africa, the ratio of nurse or doctor to patient is really high, up to 10, 20, 50 times compared to our the developing countries. So there's the actual lack of numbers, but the other lack is the quasi-lack, which comes from absenteeism. I had shared it in my slide, where for us, absenteeism in Kenya has now improved. It was in the 40%, and now we are having more people present, about 57% available. But thirdly, it also happens because of fatigue and burnout, whereby if you look at the number of people accessing healthcare in Africa, and for example in Kenya, because of increasing or improving the financing of healthcare and reducing the out-of-pocket payment through subsidies and other innovative financial ways, we've increased the number of patients coming into the hospital. But because the healthcare workers haven't increased, they see many patients, but the quality given to the first patient is not the quality that the 15th or 18th patient gets. So those are three ways in which we have lack of human resources in Africa. How can we deal with it? So I'll go back to what Dr. Buki talked about. Use of technology will be very good. Reviewing our primary healthcare models that we have, rather than having patients all having to come to facilities. Is it possible that we are able to devolve it further into the community? And for us, having community health volunteers using our retired midwives has made that easier, so that there's still skill that is being passed on. Public health education, vaccination. Must they see a nurse to get a polio vaccine in the mouth? Or can a community health volunteer be able to do that with the right accountability structures? Then secondly, use of more substitution. It's very expensive to train a doctor. It's cheaper to train a nurse practitioner or a clinical officer. We need to train more and more of these lower cadre people. The studies that the Ministry of Health in Kenya showed in terms of compliance to guidelines and treatment showed that for doctors, compliance was up to 54%, for clinical officers was 51%, and nurses was 47%. So the difference is not too much. If we just put a little more effort, I think we can find ways around it. I hope it serves to answer your question. Thank you.
All right. Thank you very much for that, for trying to wrap it up in because it's very, very wide. And I love the way you were able to, in that short space of time, actually, deal with that question. So I'm going to take the question from Mr. Kola really quick, and that's because we have questions just pouring in. And that was about, do you have any recent success stories in raising capital for healthcare startups, especially during COVID times? This person is particularly interested in greenfield healthcare facilities in sub-Saharan Africa during COVID times. So real quick, Mr. Kola, because we have other questions. So Mr. Christopher wants to know if there are any recent success stories.
Okay. First of all, Afya Care that I co-founded is a success story. We just acquired a healthcare facility in Lagos in the middle of COVID. We're chasing others. We're going to close our Series A funding by October this year. Of course, I can't mention the amount now, but it's enough to get us started on our journey. Prior to this, I had actually raised about $45 million in equity for a greenfield healthcare facility in Lagos, but this was before COVID, but the principles are still the same. The general rule for us is that we don't really think going the greenfield route is the best thing you should do in Nigeria, and probably in other parts of Africa at the moment. We also don't think that you should try to do a lot of debt at the start of a healthcare facility. It's always important to find the kind of investors who are committed to the long-term nature of healthcare investing. Otherwise, you would actually get it wrong from the very beginning. So the key lessons for us was that after successfully raising equity for a greenfield facility, $45 million, including funding from the IFC, for a project that eventually couldn't take off because of lack of debt, we've realized, first of all, that it's not really good to start with greenfield, except if you are almost like a quasi-government or institutional body, if I can put it that way. Then secondly, it's not good to start your healthcare journey with debt. It's always important to start with as much equity as possible. You can always gear your funding within a year or two after starting.
Okay. So I hope this answers your question, but I'm going to, and I feel like I would have loved to discuss that more. As with every other response that I've gotten, I feel like we're being robbed of the time to really get, but I actually want to be able to answer to give every question a fighting chance. How do we deliver quality healthcare, reducing the risk of internet fraud and patient privacy? We're going to get back. How do we deliver quality healthcare, reducing the risk of internet fraud and patient privacy? I'm leaving this open to anyone that can really do this in less than a minute, because I still have like a couple more questions. So I think I'm going to give this to Dr. Muideen, using CarePay as a little prototype. So this member of the audience is very interested in internet fraud and patient privacy when we're talking about digitalization.
Yeah, thank you very much. The CarePay platform is actually a very secure platform, because of course we know that one of the challenges with technology advancement in this new era is the issues of fraud and all of that. So for the CarePay platform is a secured platform that also ensures the patient's privacy at all times. And of course, because everybody wants to build trust. Like I said, trust is an issue when we are talking about delivery of healthcare services, whether in financing health, whether in delivering of quality healthcare services. In the continuum of care delivery, privacy and security is very, very important. In fact, for you to know, even as part of the Safe Care Quality Standards, security issues are part of the standard issues that we address. So we don't take security issues lightly at all.
And neither do they. Yeah.
Neither would they, definitely. So it's a very trusted platform. Yeah. Thank you.
Yeah. Thank you. So I'm also going to take two questions. I'm kind of going to mash them together. And this is very pertinent from Farida Yahaya, who says, the lack of financial motivation for healthcare workers, especially for doctors in Nigeria, have a direct impact on achieving UHC. I'm going to just jump in to say the lack of financial motivation for healthcare workers is almost prevalent in the entire of Africa, and it does. But I'm going to let Dr. Joan. No, actually, I think I want Dr. Joan and Dr. Kola 1 minute each, because I wonder how Dr. Kola and Mr. Kola, you see, when you stay around, I was just going about to give you an honorary degree.
Yes, yeah. I get that.
So I was just going to say, what would the solution for that from a private player be? Mr. Kola, I'm directing that to you, just 1 minute only. And then I'm going to let Dr. Joan speak on the experience in Africa, in Kenya, or somewhere else in Africa, about the lack of financial motivation for healthcare workers and how this directly impacts achieving UHC.
Okay, very quickly, I would say that the trend we see is that 60% of healthcare costs is actually staff costs. And but when you check a lot of private hospitals that we have looked at, they are not getting those percentages, primarily because there are a lot of other inefficiencies, which if you actually take a good look at the businesses, you'll be able to cut off all of those things, and then you can then pay your doctors better and pay also your other staff better. So we think that is possible. We think we're working on that. The second thing is that the incentive structure, nobody has been able to grasp maybe a way, for instance, to pay surgeons, while surgeons are still on your staff, but you still have an incentive structure that pays them on the volume of the work they're doing. People have been able to crack that kind of a code, and we think such things, when done, would radically change the way compensation is done and would help retain people more.
What about community health workers?
Community health workers, we think that if these models are done, healthcare is a system. Once the good model is done anywhere, it would actually be adopted. It would be easier for it to be adopted across board. That's what we are. Yes.
Okay. Dr. Joan, I'd love for you to take a big crack at this. The lack of financial motivation for healthcare workers in Kenya have direct impact on achieving UHC. And maybe if you have one quick nugget of how we might be able to leapfrog this particular challenge.
So healthcare workers are expensive to hire. And it makes it more expensive because the society requires them to present themselves in a certain way with prestige. And therefore, there's a pressure that comes upon them to live a certain way, to have their children in a certain level of school, to drive certain cars, simply because they are called doctor in their society or healthcare workers. And so how we tried to grapple with this, and I'll give different public and private examples. For the public sector, I'll take one of the counties that was a pilot for UHC implementation, Makueni County. For them, they were able to start paying their community health volunteers to be able to motivate them to participate in the preventive and promotive aspects of healthcare. And Makueni County, if you just Google it, is one of our success counties. It was among the first 4 where we implemented UHC before we rolled it out to other counties in Kenya. I'll give an example in the private sector where I worked in the hospital, and we sought to build our own talent because we realized we could not afford to employ this highly qualified surgeons who have their masters and have subspecialized. And what we did is we gave them incentives, and these incentives involved value-based reimbursement. Therefore, the performance appraisal system did not look at the total number of patients you saw, but rather it looked at how well you saw the patient. So for example, in obstetrics, we'd look at if you have lower rates of cesarean sections and if they're indicated. In the neonatal unit, we'd see how quickly we are able to wean off children from the cooling machine. In the anesthesia department, it will be how are we able to manage emergency blood requirements so that we could be able to save lives. And then over and above that, we ensured that we sponsored them for conferences and workshops so that they never had to pay for that. It was a requirement. And the researches they did, we actually supported them to find avenues to go and network without outside of the country. Then finally, we sponsored them for subspecialty training, but we made it cheaper by collaborating with associations abroad, like the European Society of Anesthesiologists or American Society of Cardiothoracic Surgeons. And so what we did was leverage relationships by virtue of being an institution, give that as an incentive to the doctor so that we didn't have to pay them so much, but the exposure that they got as clinicians made it worth it to stay in the hospital. And for us, we were able to also share our good outcomes because their performance appraisal was based on patient outcomes. So if we actually transitioned to value-based reimbursement, whereby outcomes are the ones that facilitate or enable us to increase your pay, then it's a double-edged sword. The provider benefits, the doctor benefits, but even more importantly, the patient benefits. Thank you.
Yes, thank you so much. I love the answer to that question. On one hand, Mr. Kola says we can actually increase financial motivation if we reduce wastage in state spending in other parts and then in other aspects of healthcare spending. And I love the way Dr. Joan put that we can also provide a lot of motivation that are not necessarily financial directly into the pocket of the doctor, which means that or the healthcare worker, which means that it might be an old assumption that financial motivation is the only way to get healthcare workers to work on that, you know. And I don't blame anyone who's done that, because every time the complaints have been from healthcare workers, it seems as if they're always saying we want more pay, more pay. But if you really listened to what they were saying, what they would like to achieve with the more pay, sometimes the more pay can equal, I'd like more pay so that I can, you know, improve my training. And if you solve some of those problems on the back end, then you may not necessarily have to, you know, be stressed for the money to put in their pockets. Thank you so much. As you can tell, I'm a bit biased. I love that question a little because I'm a healthcare worker, and you know, financial motivation is always a good thing. So I think the final question that we might just have the time for, and thank you so much to everyone for all the questions. Thank you so much for the panelists and great attempts to bring these questions. But I think the only thing that we might have time for is someone says, what are the impacts of lack of proper education or training of medical personnel and prevalent government corruption in achieving healthcare in Africa? So that seems to be like two different questions that he wants to know about prevalent government corruption. And I don't know if we're going to be able to first agree on whether the government corruption is prevalent and how relevant it is to this conversation, or how we might need another hour for that, I think. So the impact of lack of proper training or education, I think in a way, Dr. Joan has given a very clear footprint of how that could be done by leveraging with other institutions, partnerships with other institutions to kind of, improve training opportunities for higher cadre staff, and of course also prioritizing lower cadre staff. I'm very partial to community health work, so being able to actually standardize and integrate community health work into especially what we're talking about, universal health care. So I think I'm going to, you know, use my my moderator, my moderator, what's this word? I say that question has, or
powers.
Yes, to say that question has very well been answered. So which brings, all right. So as someone asked, Dr. Muideen talked about digitalizing our database. How close are we as a country to achieving that? I'm assuming this person is speaking about Nigeria. So Dr. Muideen, I'm just going to sit back in my chair. And so they fired you, Dr. Muideen. So you have to respond in 1 minute. We literally have 1 minute before we circle back and close up.
Well, interestingly, PharmAccess is working with a number of states in Nigeria, Lagos, Kwara, and some other states. And I can tell you that the states are very passionate about attaining UHC and, and leveraging on digital tech because they have seen the advantages that it poses. Because you'll find out that, again, I would say a data-driven system poses a very, very effective and efficient processes in the healthcare space. So we're just kicking off. I mean, like we say, tiny drops of water makes a mighty ocean. And of course, we have already started even engagement at the national level to drive advocacy for government to leverage on digital tech in ensuring that transparency of processes and ensure accountability and all that, so that people can trust the system and they can key into the policies of the government. Thank you.
Thank you very, very much. Now, this is a question I'm only going to mention, and at the end of this, Mr. Femi from Brixton is going to tell us how we can continue the engagement even after this. So if you have a question that has not been answered within the block of the time that we have, we're going to tell you how you can continue to engage with the panelists. And to lead with that, this is a question that we'll have to take that to that platform. So I'm just going to mention it, and it's for Mr. Kola Oni to start to think about. And he says, so I think it's a circle back on the question you'd already, and he said, Mr. Oni, can we avoid financing greenfield healthcare projects when there is a significant lack of quality and safe facilities overall? Or is this where the scale of these projects become important? You do not have to answer that. In fact, I'm stopping you from answering that because we have run out of time. But this is to tell you, Joan Adesioye, that we do see your question, and we will we'll love to continue to engage with you, and we'll let you know exactly how this can happen. So this is to say, I wish we could go on as you guys. I don't want to let any of the panelists go, but unfortunately, we've come to the end of this session. I had a very enlightening time, and I'm so proud and very honored to have moderated with these experts in the field today. And I'm taking some very important lessons away from this session, and I hope that all of the audience, which were very honored and grateful that you shared your time with us. You could have been anywhere else, but you were here, and we're very grateful for that. We don't take it for granted. Again, for the third time maybe, there is opportunity to continue to engage with this platform after that, and we're going to let you know how this is done. So I'm only just going to give each panelist 1.5 minutes, and I'm afraid I'm going to have to be extremely strict on that. In fact, it's going to be 1 minute to just give like literally 1 minute roundup, and then we're going to have to close the session. So it's going to be Dr. Muideen, Dr. Joan, and Mr. Kola. Boom, boom, boom. So Dr. Muideen, to you real quick.
All right. So in rounding up, I just want to say that we should not lose faith in the fact that we can attain UHC in Africa with the passion, the right data to work with, the right human resource, and every other political will and choice from government and all stakeholders. Everybody is a stakeholder. Once we make up our mind to say that health is the most important and that without health, we have nothing, we know that UHC is possible in Africa. Thank you very much.
Thank you so much for doing it in less than 1 minute. Thank you so much. So Dr. Joan, do you have any closing remarks?
Can only be solved by us. So if we look within ourselves, we have a lot of potential, and that's why you're developing in the developed our world and come up with the local solutions, because we are able to during COVID resources. So it's.
Thank you, Dr. Joan. Mr. Kola, any final last roundup?
All right, I would say that to achieve universal health coverage, of course, we need to make government funding more efficient. We need to ask ourselves, where should government deploy money the most? Sanitation, water supply, all these things actually cause more diseases at times. And the more operational things, we need to find a way to use a top-down approach from the private sector partnering with the public sector to do it. Secondly is that we really need to think about scale from care pay, scale from pharma, using technology so that things are really done in such a way that Africa can go to the world and negotiate in bulk. And finally, for Dr. Joan Adebukola, I want to say that a greenfield business is actually different from a greenfield hospital. We need to keep building greenfield hospitals, but we shouldn't try to raise financing for greenfield businesses. Just so much. Thank you.
All right, so thank you so much. I'm going to have to let everyone go now, but like I said, I'm going to make this quick announcement that this conversation and this engagement continues beyond this panel, and that we would love for you to join us and continue to ask these questions on the Resilient African Week on LinkedIn. It's a discussion forum on LinkedIn. So if you don't have a LinkedIn account, it's a really good time to get one. So get on LinkedIn, search for Resilient African Week. You find us, you can see the discussion forum, where I suspect that Mr. Kola Oni will be taking up with Joan with this greenfield discussion. I suspect somehow that it's really not over. But for everyone else that has questions that they want to engage with us, we're very happy to do so. Again, it's to go to the LinkedIn and join the Resilient African Week discussion forum. Thank you, and this is where we're going to bring it to a close. Thank you so much for everyone. Thank you to the panelists, Dr. Shittu-Muideen. Thank you, Dr. Joan Osoro, Mr. Kola, and this is where we're going to end for today. Very happy to have spent this time with you.
All right.
Thank you.
Bye, everyone.
Bye.
Bye. Thank you all.
Thank you.